offer to Corrina Keeling, who I mentioned this morning, has been digitally and visually capturing all of the conversations from the day. And Corrina, I believe that you're mic'd up and ready to shine. All right.
Can you hear me okay? Hi, everyone. So just before I begin, I'm going to do a quick summary because I know that we're running a bit late. I just wanted to let you know that my role here is really to be listening to the room, not only to what's being spoken, but also to what's landing with the audience. I'm a lens, I'm a filter to sort of capture what I hope is the kernel or the heart of the conversation. So before I begin, I just want to let you know, please feel free to come and interact with me and interact with the charts afterwards. And they belong to you. They belong to this room, so I'm not precious about them. If there's spelling mistakes or if there's concepts that I've misunderstood, please feel free to let me know. I want this to accurately reflect the experience that you had in the room today. So starting off at the beginning of the day with an introduction to the Women's Health Research Symposium, talking about today's themes, which is women's mental health and also knowledge translation, closing that 17-year gap between knowledge and research and actual action and policy change. Asking the question, why women's health? Having a keynote from Jyoti Samra, around the idea that gender is a health indicator is grossly overlooked and under-respected. Putting our hands up to realize how much this issue affects every single one of us, whether directly or indirectly. Making sure that we remember that this work happens on unceded Musqueam, Squamish, and Tsleil-Waututh territory, and what that means to be using an intersectional lens and using a lens of colonization to interpret all of the work that we do. This issue has a ripple effect because when women suffer, so do children, so do elders, so do families, so do workplaces, so do men. Women face unique risks that are specific to this demographic. Violence, assumptions, trauma, barriers, stigma, risk, demands are all specific to this demographic. Touching a bit on depression and how it's not a first world issue like the assumption often arises. That it's actually a global issue, and then in Canada, it affects 1 in 5. As women, we are socialized to self-evaluate, we are socialized to internalize, we are socialized to obsessively compare, and that is one of the factors that contributes to that number. Some of the notes that I didn't get to yet is that shame is one of the key factors that contributes to the barriers of being unlikely to have access to treatment. Focusing on the need to focus on the education of men in order to contribute to women's health issues. And a quote that stood out for me is, it's only by women sharing with other women that the field of women's health will change. This one. So moving on to the first conversation, discussing intergenerational transmission of depression. How daughters of depressed moms, because of the overlapping factors of them being inherently women and also having a family history of depression, that it actually makes them more than double the risk of having a depressive episode during their life. And that the crucial component there is intervention to identify who's most at risk using dysregulated diurnal cortisol levels and use that as an early indicator for depression. Oh, backing up, we had a little bit of a context setting, which is just talking about the layers of stigma, talking about self or internal stigma, and how that leads into social and public stigma, and also how that contributes to institutional or structural stigma, and how they all have a relationship with each other, that they don't exist separate from one another. Something that stood out for me again is that it takes power to stigmatize, but also that it takes power at every level of those layers of stigma in order to change it or undo it or unravel it. An opportunity to discuss eating disorders and how, again, similar to the other assumption that it affects, just an upper class or just a specific demographic, eating disorders affect all women and all girls at some point. And in terms of the way it's impacted in the demographics. Intention matters. Taking not a directive, but a collaborative stance when approaching eating disorders, to be able to focus on readiness for treatment, and also to have a sense of mindfulness for providers and how that contributes to solving the problem. Looking at postpartum depression and anxiety, MBCT, mindfulness-based cognitive therapy, and the reason that looking at postpartum is important, the reason that matters is because it impacts bonding, which is an indicator of interpersonal success later in life. And MBCT is seen as quite promising for treating anxiety, depression, and mindfulness in the studies that were done. Looking at mandating using sex as a research variable and how that's a great thing to have happened, but questioning whether or not this data will actually be analyzed appropriately, whether we have the tools to interpret the data that's being mandated to include sex as a variable. Looking at unconscious bias, the little picture of the two resumes side by side and how one was weighted over the other because of a name. All demographics contribute to this. It's not just men that contribute to bias of women. Women who are measured as excellent are about on the same level as men who are measured as mediocre. This was a really impactful graph for me and really landed with the room. The opportunity to take the Harvard Implicit Association test so that you can know your own bias and know the way that you contribute to perpetuating biases. Looking at the way that women are socialized to use softer language, I think my belief, this came up over and over again today, and that this actually makes women be evaluated lower and impacts credibility. And moving into the next conversation was that credibility is fundability. Equity in health funding is a huge disparity. We have to consider the whole research pipeline from the beginning at who applies, who gets funded, what is the status of organizations and institutions and centers, and how that contributes to the back at the beginning of the pipeline of who gets funding and who's applying to begin with. Suggestions to find allies to navigate the system, and I think there was actually some folks who put their hands up to help to do that. Achieving diversity looks like encouraging each other to apply. So again, in the same way that we're socialized to use softer language, we're also discouraged from applying or are less likely to apply. So make sure that you encourage each other to apply, and also ask for what you really need, not less. We also talked about migration as a determinant of health, wanting to expand the view of this issue beyond just infectious indicators, and talking about how health access barriers and human rights and protection in those conversations are linked and actually can't be separated. You can't have you can't have one conversation without having the other. Looking at fetal alcohol syndrome and the success that British Columbia has had and the leadership that British Columbia has had by creating a virtual community. And within sort of the 4 puzzle pieces of the program, really focusing on number 3, which is talking about at-risk moms and what the conversation is about mitigating that risk. A conversation which was super relevant to me, which was arts-based research for mental health. Focusing, again, looking back on those areas of those layers of stigma, this is an issue that really focuses on the issue of self-stigma and addresses and mitigates that issue. It's successful because it denies and overwrites internal oppression, and it has an opportunity to gather data from an intuitive space rather than a cognitive space, and that's a crucial contribution to successful research in this area. Creativity is essential for women's health. Hearing a little bit about the opioid crisis. Women are more likely to be prescribed opioids for pain management and therefore end up with higher doses. They use it more for pain. They end up using it for longer. They end up with higher dependency rates. And so what's needed is a range of treatment that exists in gender-specific settings and hopefully also working towards ways to manage pain without relying solely on opiates. We then had a memorable keynote from Erica M., the art and science of knowledge translation, how storytelling, social tools, and building an audience combined with research, data, and scientists can actually sort of make a magic formula. Using social media to get data and information into the hands of parents who need it now. So the process and the sort of formula of turning really, really dense data into social images is what she called it. The key messages that are needed to really move the needle. And success when you're doing that kind of work looks like trusting your creators, investing in amplifying your message, not just creating the message itself, building the community who's going to receive the message and who can help the amplification, and also naming your leader. Make sure that there's a face to the name of your project or the work that you're doing. Last, we looked at women's health in a global context, how HIV is a gendered epidemic, combining the issues of women's inequity, colonizations, patriarchy, power. Again, those are conversations that you can't pull apart and have separately. A little image of the condom and why that's, how that was a disparity in how research and prevention was focused. Measuring sexual self-efficacy tells us that improving knowledge in men prevents infection in women. Having a conversation about maternal health and some of the shifting and changing conversations and statistics around maternal health based on some of the treatments that have changed. And really outlining the idea of women-centered care, which is care that it's different than patient-centered care because it's not paternalistic and it doesn't prioritize a maternal identity over an individualistic identity. A conversation about how can health systems meet the needs of meet the changing needs of women in a world that's constantly changing, and how the two areas that were prioritized in that is integration with health systems and also resilience, so being flexible, being decentralized, and being community-based. Talking about patient-oriented research in the context of women's health. So lots of voices saying we need to set the agenda as patients, and that not just patients, not just using the language of patients, but as people, as individuals, having us be partners in the research. And to ensure that there's a vigilance to a social justice lens, that it's not just better care for those who will benefit from it most immediately, but it's better care for everyone. Moving into BC's impact around gynecologic cancer, understanding the impact and role of fallopian tubes. I really appreciated the conversation, had a direct impact in my life. Thank you. Understanding how women with HPV testing means that had less than half the risk of those who were just tested with a PAP, and what the implications of that. And then moving into the question of, okay, so how do we roll out this knowledge, and having a conversation around vaccines and disseminating that to the public, turning the page on the burden of women's reproductive cancers in four main areas: prevention, prediction, treatment, and living with cancer, and how those are all require distinctly different approaches. And then lastly, we moved into a conversation about mapping the future. Some of the highlights of that were highlighting sex and gender in all key areas of research, not just as a separate silo of research. Understanding and amplifying that women's health is at the heart of an innovation agenda. Making sure we understand the link between communication, collaboration, and data. Making sure that we have effective platforms for data so that the people who need to get the information when they need it have access to it. Really embracing tech and imagining what the future could be. Ensuring that we keep growing the network. To hone our messages to government and think about delivering solutions that are ready. And also a conversation around the importance of leadership within the sector that has an analysis of this issue and who can continue the conversation in a meaningful way. Thanks.
That was absolutely outstanding. Thank you, Corrina, for capturing the day. We invite all of you to come up to the third floor in the Shaughnessy building where these beautiful posters will be displayed. And Corrina will also be making some digital images of them, which we'll be disseminating through various social media channels. So we've reached the end of really a truly outstanding day. We have one final presentation, but I want to make sure we have two separate rounds of applauses for two really important individuals that pulled this day together. One was Lindsay Callan and her team from the UBC CPD office. And so huge thank you to Lindsay for organizing this incredible venue, the food, keeping us organized. And a second thanks to Catherine Dewar, our Senior Research Manager. Catherine really deserves all of the credit for the day. She was really the brainchild and the power, the horsepower behind pulling this day together. So thank you to Catherine very, very much. Also, thank you to all the WHRI staff for all of the months of work that you put into the thinking and the planning, and especially on this day, keeping the social media going, keeping us entertained, et cetera, at the front registration desk. To Gina Ogilvy, who oversaw the creation of the awards. Thank you to our sponsors, again, the Women's Foundation, BC Women's Hospital, PHSA, and again, Michael Smith Foundation. Thank you to all of our amazing speakers. And really thank you to all of you who have participated enthusiastically and generously with your time and your enthusiasm and your passion for women's health research. So before we adjourn to the more social events of our program, I'd like to invite Jeff Sadowski, who's the Senior Director of Principal Giving from BC Women's Hospital and Health Centre Foundation, who will be announcing a special gift.
Thank you, Lori. I would just say that as the Senior Director for Principal Giving for the Hospital Foundation, and we have a special relationship. We walk the journey with you, right? It is our privilege to solicit funds on behalf of the Women's Health Research Institute and to receive funds for the Women's Health Research Institute. And so to that end, I would actually encourage all of you that are not members of the WHRI to become members of the WHRI. And for those of you that are members, to be quite active in communicating to your contacts what you're working on and what your needs are and what your progress is and all of those things, because those conversations translate to hopefully relieve some of the frustration that I heard in the last session. So I'm eager to have just a small celebration from one of those conversations that was able to match an opportunity with a need and build that bridge. So in order to do that, I would like to invite Nicola Hartigan and David Klein from Klein Lawyers.
Hi, I'm David Klein. I'll explain the mystery of the gift. Our firm does personal injury work and class actions. About half our class action cases are pharmaceutical and medical device cases, mostly products that are removed from the market because of the harmful side effects. And a disproportionate number of those drug and defective medical product cases actually affect women. So this particular one, this particular check and donation arises from the silicone gel breast implant class action litigation, the first class action that was certified in British Columbia, but we have many others that affect women. The Fin diet drugs, about 90% of the women, 90% of our class was comprised of women. HRT, breast cancer cases, of course, transvaginal mesh, Teflon-coated TMJ implants, probably about 70% women. Dermalive, which was a dermal filler that was withdrawn from the market. So we see this interface with defective medical products and the female population. The source of this problem is really a lack of research at the outset before these products come onto the market. What's happening is that patients, and very often women, are used as guinea pigs for drugs and medical devices. The research is either inadequate or non-existent, almost non-existent before the products come on, and then a lack of research after the products come on. So we see products that shouldn't be on the market or that are withdrawn too late or with warnings that should have come on sooner. This particular one was the silicone gel breast implant case. Our lead plaintiff, Helen Harrington, had double mastectomies, and to make herself feel whole again, had breast implants. She had a particularly notorious form of breast implant called the MEM. It was coated with a polyurethane foam that was supposed to reduce the incidence of capsular contractures, but in fact, it was a foam that was used in a car insulation, and over time it would disintegrate and break into little particles, which would cause an autoimmune response and granulomas. And Helen Harrington had tremendous courage. We wanted Helen to be here for this donation, but she'd recently suffered a stroke and wasn't able to make it. It takes tremendous courage to come out and be the face of one of these cases, and she demonstrated that courage, seeing the case through what turned out to be 2 decades of litigation. It ultimately resulted in a $40 million settlement because of women who had passed away and couldn't receive their settlement checks that went uncashed. We had of that $40 million about $118,000 left that had to be spent in a worthwhile way. We contacted BC Women's to get their input on what they felt would be an appropriate use for the money that was left over from the silicone gel breast implant litigation. And they identified very quickly a project that does genome mapping for breast cancer. And it's just a delight to be here and to be able to donate this money to a very worthwhile purpose. Thank you.
Well, that concludes a truly incredible day. Look forward to conversing with all of you upstairs, where hopefully we can continue some of these conversations. So thank you again, and we'll see you all here next year.